Thank you very much. First of all, it's my pleasure, it's a privilege to be here, and I have to thank the organizers for providing me with the opportunity to share our small experience, but probably because it is so small, it makes it interesting for some centers or some colleagues that are thinking about introducing this interesting and good therapy. What is the rationale about how we use this therapy, BAT? Well, sorry for that, but I come from the EP side. I'm a rhythmologist, and I'm running the full department. I'm trying to provide my colleagues dealing directly with heart failure patients with all the tools available to help the patients. So, first of all, the idea is that the people, the colleagues that are treating these patients have all the tools in the toolbox in order to impact in this orange area, this window of opportunity of patients that will not get a transplantation or will not get an LVAD, or probably later. Second idea is that we use this therapy on top of the other neurohumoral control we can provide to the patients. We consider the central nervous system as a partner in doing this. So we stimulate the brain and let the nervous system to do his job or its job probably better than me. Who we are? So we are a general hospital with some population, 500,000. We have a lot of hospitalizations. What is more important about the cardiology departments, we have the full portfolio and we have, let's say, a good activity, more than 500 primary PCIs. But what about heart failure? We do about 20 transplants a year. We have hospitalizations. Not all the hospitalizations are in cardiology. Our colleagues of internal medicine do a lot of it. But we share this activity. And what is important, we have about 800 patients with reduced ejection fractions, severely ill patients that are treated in a special program. And what is important, we have a very low rate of rehospitalizations in this program, below 6%. We are proud of this. Second, the procedure. This is the reason I apologize at the very beginning. For me, an implant is not a scaring issue. But I have to say to my colleagues in the heart failure clinic that an implant is a part of the treatment. It's nothing to be scared of. The implant, let's see, is a little bit difficult for a non-implanter, but I can say that the surgeon can manage it very easily, and they feel really engaged when they see the acute results on heart rate and on the pressure. This is the procedure. What about the patient in the team? Who is our candidate? Our candidate is this one. Left ventricular ejection fraction below 35. The patient still have limited symptoms despite optimized therapy. Because I know you all heart failure specialists optimize the therapy, but only with pills to your patients. And finally, not suitable for CRT. This is an important point. We do not restrict the device to patients with NT-proBNP under 1600. We included every patient. These are patients very sick, and they claim every day at the clinic, they claim at the office, something to improve their quality of life, to improve their symptoms. It's very important to make, let's say, a very good team all involved, and this is what we did at our hospital. Well, this is a single case. The ECG, the patient with the defibrillator, and then the device on the right side of his neck. And this is how the ECG looks when the device is doing its job. Then, second part, and is done by the heart failure specialist after a couple of weeks, The device is optimized in order to get the more from it, in order to get the more benefit, and it's done in the hair failure clinic, and it takes time, but not so much, because our patients are visited more than what is imposed by the protocol of optimization. Which is our experience? I will show you data only of our 10 initial cases. And when I show 10 initial cases, it's better to show, let's say, a full perspective rather than a statistical mean or median or deviation. There are so few that you can have you look at that. So this is the first 4 patients. You can see in drug treatment that they were all, let's say, close to fully optimized. And you can see that this is a feature of our series, that significant part of our patients were non-hypotensive or were intolerant to beta blockers. And this in some way provides us with the opportunity to introduce BAT. This is important. And as you can see in the lower rows, the patients, some of them have had significantly high NT-proBNP levels, and despite of that, we introduced the therapy. In some patients, we performed some controlled effort tests, and we could see how in the patients we did it, it was improved. The functional class, the heart failure functional class, the NIA is on the 4th row from the bottom, and you can see how there is a significant general improvement. These are the second 6 patients. You can see with me that they all are fully optimized, lots of medications, and despite of that, the patients claims for something better. Bolded, you can see the significantly high number in the NT-proBNP levels. But you can see that despite these very high levels of NT-proBNP, the effect on the functional class, the quality of life, and even the NT-proBNP and left ventricular ejection fraction was not different at all as compared with the patients below 1600. This is our short little experience I want to comment to you. There were 2 patients, one went into heart transplant. It was okay after more than 2 years of the therapy, and one patient, the patient number 6, died. It was a very, very sick patient, a class 3B, impossible to deal with. This is exactly what I wanted to share. Let's put together all this data, all these figures, and let's make it short. Our patients were an average year of 63, 90% men, this is how it is. Ischemic heart disease, 60%. In the patients with reduced ejection fraction, because one of the patients was included in the initial series, has a preserved ejection fraction. And these patients, the increase, the median increase is close to 10%. And in the cases we do oxygen consumption, only 4 patients, I have to say that, this was a significant improvement. This was we had, but on the right side, what is important for our patients is that the red color is the patient that improved significantly their functional class and are in class 1 or 2 is much, much higher. We don't need figures, we have colors in this case. And the significant reduction of NT-proBNP levels was close to 40%. It means what it means, but the patients were happy with that. Probably you guess about what can we conclude with this so small number of patients. What I want to share with you is this, which is the description of our experience. It's a very short and heterogeneous series. Second, our inclusion was not restricted by NT-proBNP. Third, it was significantly driven by non-hypotensive or even, let's say, close to hypertensive patients. And finally, what I can say is that truly confirms our initial experience. Which is the analysis? The analysis is that it's a very, very safe therapy. We have no complications and no claims for the patients after having received the therapy, because it's not so easy from time to time to convey the patient that after giving so much drugs, probably he needs a device or she needs a device that is not a pacemaker or defibrillator. This is something different. Let's say that is completely safe. It was very effective in improving symptoms, quality of life, NT-proBNP, and finally, this is one part of our analysis. It's open to discussion and criticism in very, very sick patients at the end stage of their lives. Probably the benefit may be compromised, which is our perspective. This therapy may be considered earlier in the life of our patients, and second, probably may be considered for a larger population. And this final line is something that you probably know better than me. There is an increasing population of patients, probably of advanced age or whatever, highly committed to living a better life rather than a longer life. And I guess this therapy may be of help for them. Thank you very much.